It's a great pleasure for me to be here again as the co-chairman of this fantastic meeting. I have a long story with the EAO because I entered in the board in around 1996. I was around 40 years old. And in the board there were all the legends of the implant surgery, bone regeneration, like Danny Buser, Sasha Jovanovic, Friedrich Neukamp, George Vacek, all people that I see here, and it's a place where I see all the time friends. And I organized already a meeting in 2001, and we had 2,000 people, but 3 days before we had the problem, the collapse of the Twin Towers, so we had a lot of problems. We worked like crazy. At the end, the meeting was successful. So it's fantastic to be here again in the EAO that from that moment grew like crazy. So I congratulate with the board, with Luca, with Isabella, with everybody that has been in the board. And so I thank you very much for being here. And I'm very happy also to bring the word of, on behalf of the Italian Academy of Osseointegration, who did a great job to promote this meeting. So thank you, and have fun with the meeting.
Thank you very much. Next up, on behalf of the Italian Society for Periodontology and Implantology, the President, Francesco Cairo.
Thank you. Thank you, dear friends. It's a great honor and pleasure for me to represent my society, the Italian Society of Periodontology and Implant Dentistry, the CDP. More than 35 years of history as a society, more than 3,000 members, and a lot of members that strongly contributed from the CDP side to the development of knowledge or perioculture, implant culture over the last 30 years. So we are so happy to join EAO and EAO and this incredible, astonishing meeting. We are opening our doors and opening our windows, and we are really happy to create connection among incredible people to spend all together 3 beautiful days. I want to thank you, Ronnie and the EAO board, Isabella and Luca Cordaro. They did an incredible job. It was really amazing to work together for a long time, and I'm sure that this will be 3 unforgettable days. Thank you very much.
Thank you. May I invite all the chairs to come together at the front of the stage, because we officially need to get this party started, but not before I ask Isabella Rocchietto as co-chair to give a final word about what's happening after these 3 wonderful days.
Yes, welcome ladies and gentlemen. I just want to give you an insight that from November 5th, the Milan 2024 meeting will be available free for everyone online on the digital platform. This will give the opportunity to everyone to access the breadth of knowledge that will be shared and delivered in these 3 exciting days. So whether it's for you guys, and perhaps you may have skipped or had to choose between a session or another, or perhaps our friends and colleagues who could not manage to come here physically in Milan, from November 5th, everything will be available. So thank you very much. And now, let me please come here, gentlemen, given I'm the only one here. So we made it, guys. Yes. Okay? Yeah. So 1, 2, 3, benvenuti!
Thank you, thank you, thank you. Chairs of this Congress, you must be so proud. Congratulations. You came through the opening ceremony, and it's now time to get this meeting started with the first plenary session. We are going to focus on the challenges of multiple missing teeth in the aesthetic zone. Plenary 1 will be chaired by Massimo Simeon. You're already on stage. And please welcome to the stage his co-chair, Irena Saylor.
Thank you, Gerrit. Allora, benvenuti tutti. Welcome, everybody. This is breathtaking. We can really say, Massimo, the EAO is back with the help of the Italian societies, and it's so amazing to see all of you here, and I think we should go more to
with a big help. Look at how many people.
This is fantastic. Thank you all for being here, and we're very honored, proud, and also excited to be the opening session here, to moderate the opening session with a very challenging title, The Challenges of Multiple Missing Teeth in the Aesthetic Area. And of course they're challenging because we have numbers of questions as clinicians. How many implants should we place? And where should we place them? And how much regeneration do we need? Do we need bone regeneration only, soft tissue regeneration only, or do we need both? And how do we finalize it prosthetically to come up with a really nice, predictable aesthetic outcome? Because it's the aesthetic area and patients, of course, expect our best. And we've invited great speakers for this session. We have 3 wonderful lectures. You all have the opportunity to be part of this. Please, on your apps, you will find the session and you can send us your questions, which you might have during the lectures, so that Massimo and I can use them later on during the discussion. Yes. So with this, I'd like to warmly welcome on stage the wonderful Anne Benhamou, female speaker from France, coming from Paris to Milano. Anne is an oral surgeon. She studied and got her education in Paris, in France. She specialized in perio and implant surgery at NYU in New York. And now she is in France teaching at the university, Paris 7. She's also running a very successful private clinic. And at the same time, she's the founder of SNIF. And SNIF is a very special association. It is an association for female dentists exhibiting implant dentistry, so the Congress is always very, I would say, female supported. Anne will give us and open up the stage with her lecture on all the questions that we just raised. So what should we do? And then we will go into the details of the surgery and the prosthodontics with the following speakers. Okay. So I would say, Anne, stage is yours.
Thank you.
Thank you for coming.
Thank you so much. Thank you so much to the scientific committee for inviting me for such an incredible Congress. And thank you for Massimo and Irena to include me in this session. I could meet my colleagues and we felt the same passion. So I have today the difficult task to identify the surgical and prosthetic challenge of multiple missing teeth in the aesthetic zone. And so I brought a friend. She's not real, she's my avatar. Don't laugh, she's more beautiful than I am, but she's completely fake. She's going to be with us.
Hi, Anne. Hi, everybody. I'm Anne AI, Anne Artificial. Totally artificial, but I look real, don't I? Yes, I know I'm not perfect yet, but I'm improving. I will keep you company during this presentation, and if you like me, maybe I will come on my own next time.
No.
Don't need Anne anymore. So Anne, my first question for you is, the goal in any implant therapy in the aesthetic zone is to produce a lasting restoration of the teeth that blends perfectly into the patient's smile. How can we achieve this goal with multiple adjacent missing teeth when we know that we will have bone and soft tissue issues?
Thank you, Anne A. So you have both, you have 2 Annes today. So yes, for a single tooth, now we have the tools, we have the knowledge, we have the literature, we have the surgical skills, we have the prosthetic skills, and so we can today make some more reproducible, more predictable, and more stable in the time, because here, this one on the right is 10 years after placing the crown and the implant. So now we know how to make it stable for one single tooth implant. For multiple teeth, we can always play with the soft tissue, play with the bone, play with the restoration, and even for very difficult cases, we can always manage for a full arch to get some satisfying results. But for this kind of restorations, what do we do? Do we do implants or we don't do implants? Do we do how many implants? Where? Which position? How do we place them? So we are going to have issues with the bone, with the hard tissue, because we know that as soon as we will extract these roots, we lose the bone. And especially if we place 2 adjacent implants, we'll have more loss of crestal bone. We have the soft tissue. This is the issue. How do we do with the papilla? How do we do with the recession? And then we will have the prosthetic restoration, which is another challenge with, of course, respecting the teeth proportion and making the teeth looking natural. So at least, finally, we have 3 challenges. The surgical challenge with the pink aesthetic, the prosthetic challenge for the white aesthetic, and the human challenge. The human challenge may be one of the most important to make our patients happy. So key number 1 is the time of implant placement. When do we place the implant? Immediately or delayed? The number of implants, how many implants, and what is the distance that we are going to respect between the 2 implants. The position of each implant in the 3D, which is mandatory, of course, to have beautiful restorations, and we will have to augment bone and soft tissue almost every time. So for the white aesthetic, we have to figure out the position of the implant abutment interface relative to the bone crest. Should we place the implant on the level of the bone, just above the bone, just subcrestal? Should we use bone level implant or soft tissue level implant? The design of the implant abutment connection, we will always try to have switching platform. The material, we love the zirconia, of course. The contact point, to have the papilla. Do we make one single crown or a bridge? And something that we forget, we must not repeat removing, placing back, removing, placing back the component, the prosthetic component. That's why now we use some intermediate component away from the bone. And of course, never ever forget the patient-specific factors, which are the lip support, the lip line, and the gingival biotype. So the first key is the time of extraction. We have 2 different timings: immediate, flapless, or delayed and flap. The literature is supporting, and especially Tidou Mankou, but the literature is specialing that immediate implant placement is favorable for maintaining the soft tissue and maintaining as well the peak behind 2 implants. Of course, we have to place the implant correctly in the 3 dimension. We have to place some bone filling on the buccal, soft tissue filling, I would say, but soft tissue reinforcing on the buccal as well, and use some under contour abutment for the mucosa. When we talk about timing, we have another issue, which is sometimes we have to go in stage approach. And sometimes, like here, you see these 4 incisors are compromised, but you know this man is one of the chauffeurs of our French president. So he told me I can never be with a removable or I can never be disturbed. So for this patient, we rebuild the 2 first implants, place the 2 first implants, and make a provisional hold by the 2 teeth, and then we will extract the 2 teeth, and the provisional will be held by the 2 implants after their osseointegration. So timing, 2 issues: the number of implants. The inter-implant, so we have to measure the mesiodistal distance between the 2 residual teeth. And between 2 implants, we want at least 3 millimeters. So we have to measure, we have to see the residual bone to make sure that we can place the implant in the strategic location and in the 3 dimension, and the best position in the 3 dimension. And we will always take narrower implant and platform switching. Augmentation, mandatory for enhancing the soft tissue support, contouring, and thickness for aesthetic and function. Temporization, crucial. Crucial temporization for sculpting, guiding, and supporting the soft tissue. But not only. We can use this temporary time to make some correction if we need, or to adjust the occlusion, the aesthetic. So this is a very important time. And the last but not the least, that Carlo will develop later on, the prosthetic restoration must respect some rules. So we would love to do the A, but A would maybe create some compression on the soft tissue and may involve a recession. So we want to have space for our soft tissue, and so we will under contour all our abutment. And we will have this kind, you see, space, what we could call soft tissue chamber. And now we will use some intermediate component to be away from the bone and to have this contour. So at the end, if ever we refer to this very important schema, so we have the zone C for the crystal ball maintenance. I like it concave, 1 to 1.5 millimeter. Zone B, this is the biologic sealing, and 1 to 2 millimeter for junctional epithelium, and then the zone C for aesthetic.
In summary, to maintain the bone peak between two adjacent implants, it is essential to define the right timing for placing the implants, to ensure proper spacing between the implants, to augment bone and soft tissue, to design the crowns with a natural emergence profile, to use platform switching techniques, and to contour the interproximal areas correctly. These factors contribute to both the aesthetic and functional success of the restoration in the aesthetic zone. Okay, understood. But Anne, can we go into more practical and clinical situations now?
So let's go for 2 adjacent missing, more practical, with these beautiful drawings of François Vigouroux. And here, for 2 adjacent missing teeth, what do we do? 1 implant and a cantilever, or 2 implants? So always the same question. So we know that we want 3 millimeters minimum between the 2 implants. We want 2 millimeter implant tooth. We will look at the size of the implant. Always choose a narrower implant. Don't go for large implants. The connection for platform switching, and of course the contact point that should be 5 millimeters to the bone crest. So now we have here on the left, on your left, yes, you have Christian. Christian is 64. He's not a smoker, but he has some perio issues. And on the right, you have Cyril. He's a cook in a restaurant. He's a smoker. Both have a central and a lateral that are compromised. This is for Christian, the initial digital impression, the digital wax-up, digital extraction, and as you can see and confirm, we don't have the space for 2 implants. We don't have the space, we don't have the bone. So we will go for 1 implant and a cantilever. For Cyril, the initial impression, the wax-up, extraction, and here we have the space and we have the bone in the correct position. So here we will go for 2 implants. So we will go parallel on the 2 cases. Key number 1, we will go immediate and flapless for both. And of course with a digital guide. So in the first case, we will do 1 implant, and in the second case, we will do 2 implants. Key number 3, bone filling and soft tissue grafting for both of them. So the bone filling will be with a low substitution bone substitute on the buccal, and tunnel for soft tissue grafting, both of them. Key number 4, immediate temporization for both. What do you see? What do you think? You see, we know for Christian that the papilla between the pontic and the implant is going to be very small. So almost no space. For the other one, we can see that we start already at the provisional to work on the papilla. The tissue, beautiful tissues for both after a few months, and then digital impression, and you see again, for Christian, we won't have a papilla, we know it here, we will have a papilla. The prosthetic restoration will respect the rules that we had, like concave for our soft tissue, and these are the 2 results. So what do we think? Do we think that, what should we choose? Good, my avatar is not coming now. So Meyer made a study and a review, literature review, and on both cases for 10 years, studying 1 implant with a cantilever or 2 implants for central and lateral. The survival rate for both cases was 97%, so great for both cases. The restoration survival rate was high. The peri-implant level and the mid-facial mucosa level was stable for both cases. The peri-implant soft tissue was healthy. The patient satisfaction was very high, but for us, for specialists, the papilla and the pink aesthetic score was low rate. You have, I'm not going to talk about this, but we can discuss it then in the discussion, an in-between approach with pink ceramic. So now for 3 implants, here we have a case. This is another Christian, he's a model. He's eating only protein bars that he's crunching like this. He has a thick biotype, even if he has a poor hygiene. And we decided to place 3 implants because we have the space. Because we have the bone, because he's crunching the whole time, because I know that we can keep this implant in the time. And after 10 years, we know that we have kept the teeth proportion and we have smaller papilla, but we have papilla. This patient is different. This patient is coming, she had an accident when she was 18 and she's not coming for implants at all. She's coming for veneers. She says, I'm not happy with the level of my teeth. I'm not happy. But what she doesn't know is that she have a resorption under the two teeth of the bridge. So we are going to extract very carefully the two teeth, and in this time, because we have a high level of expectations by the patient, we are going to go delayed. So we made a socket preservation with an allograft and collagen membrane. And then we are never going with, when we can, never going with removable. After 5 months, flapless, we are placing the two implants exactly where the two teeth were, and an immediate temporization. Then the prosthodontics comes, and after checking the quality of the soft tissue, he will start with the veneers. And he made an amazing restoration by doing a framework, a zirconia framework, that was screwed on the implants, and then he could do the 8 veneers exactly the same width, the same length, the same color, because he says that we can never have the same color with feldspathic and with zirconia. So that's how we made the case, and this is how the lab technician delivered the veneers, all the veneers. This is how it was in the mouth, and this is the beautiful smile of Justine.
Hey, I'm still here. Don't forget me. I perfectly understood the recipe for 2 or 3 neighboring missing teeth in the aesthetic zone. Can we follow these rules for more than 3 teeth missing, like 4 or 6?
So for 4 implants, what are the questions? Either 4 implants, of course, 4 teeth missing. Do we do 4 implants or do we do 2 implants? If we do 2 implants, they could be on the 2 lateral, they could be on the 2 centrals, or they could be 1 central and 1 lateral. Let me tell you, everything works. It's just a question of planning and of analyzing everything. So bone volume, soft tissue inside, and mesiodistal space, of course, mesiodistal space available. This patient is a smoker. She has a poor hygiene. She doesn't really care of what is happening, but she has only one requirement. She doesn't want the space between her central. She just wants the 2 centrals, very, very close. So what are our options? 4 implants? No way with a woman with poor hygiene, or and that we don't want really the space. It's too dangerous. 2 implants in the central, or 2 implants in the lateral. This is the option that we have chosen. Always treatment planning, digital. We always go digital extraction, digital planning. And this is how we handle by doing extraction, flapless implant placement, always bone and soft tissue grafting. And after 2 weeks, you see that we think that we have the soft tissue, but after 16 weeks, it shrinked. So is it a good thing to have 2 pontics one to another? Yes, if ever we go again through soft tissue. Maybe we have to add 1 or 2 steps of soft tissue, and I think that we are going to see this just after me. In this case, it was another case. We chose the option of doing a bone grafting before. The bone grafting was done by Georges Coury. I think he must be somewhere here. And then I placed the 4 implants. And then I started working with the provisional. And slowly by slowly, we build the papilla. We had nothing. And little by little, even if the provisionals are not so nice to look at, we build the papilla. And this case, without the provisionals, would not have been possible. The last, but not the least, 6th adjacent teeth missing. Maryse is 79 years old. She fell down on the pavement and she broke her teeth. So after the while, she's coming, and so we decided to put 4 implants. I would never think about 6 implants in this case. I would always think about 3 to 4 implants. I think that 4 implants is a perfect rate, 2 in the central and 2 in the canine. Key number 3, bone augmentation. And soft tissue augmentation, we did it on the 2nd stage surgery. After 5 months, we have beautiful area, beautiful site, but we don't have enough soft tissue surrounding. So we are doing the soft tissue augmentation and, of course, the provisional bridge. At the end, we have the final restoration and the fantastic smile of Maryse.
So to conclude, we have identified the challenge of reaching aesthetic success implant treatment for multiple missing teeth. The strategies to address the issues are proper planning, including using digital imaging and 3D models, is crucial to evaluate bone volume, soft tissue conditions, and implant positioning. Techniques such as soft tissue grafting, guided bone regeneration, and using narrow diameter implants can mitigate some of these challenges. Consideration of alternative solutions, such as placing a single implant with a cantilever prosthesis, where one implant supports 2 teeth, or 2 implants with 1 or 2 oval pontics, may sometimes be a good option to provide a better aesthetic outcome.
I couldn't say it better. So with this, I just thank you for your attention and show you the rings of the Olympic Games that were in Paris a couple of months ago, and I hope that some of you came to, we had amazing sessions with all the sports. Thank you for your attention.
Thank you. Thank you, Anne, for the nice presentation. We'll make the discussion later on.
Definitely. Thank you.
So the next speaker is an Italian. He's an outstanding surgeon, Luca de Stavola. Please come on the podium. Luca has graduated at the University of Padua, and he had a specialization in Germany under the guide of Fuad Kuri. And he did also a master at the University of Munster, and is very well known in the field of oral surgery, oral implants, and what is very important also is in the board of Italian Academy of Osseointegration, and is a president-elect. So the next 2 years, Professor Heriberto Bressan will be the president, and after Heriberto Bressan, Luca will be our president. So Luca, please come on the podium.
It's for him.
Thank you, Massimo. Thank you very much. Thank you.
Crystal clear.
Okay. So thank you very much for inviting me. It's really a tremendous emotion being here and here in the stage with so many people and so many lovers of our profession. And thank you obviously to the scientific committee and to chairman of today and chairwoman of today. Thank you very much for involving me. So my topic is regarding the surgical challenging, the key factors in surgical management. And it's obvious that we have to take a lot of decision to perform a predictable bone augmentation procedure, and potentially it's better to take this decision before approaching the surgery itself. Otherwise, the stress, the tension, the human factors may generate on us some complications. So my workflow will be, if there is a picture, just me. It's not connected. Oh, yeah. Okay. Now it is. So my topic again is key factors in surgical management. Oh no, wonderful. I have the slides now, right now. Okay, perfect. So my lecture workflow will be running through diagnosis, material choice, technique, and flap. We will be quite fast on going through this overview because obviously we have a limited amount of time related, but it's important to focus on some key points. Diagnosis. First of all, we know that to have a nice tissue integration and a nice tissue profile, we must have a space from the bone stable level to the emergence profile of the crown. And we have to keep in mind this, because this is very important when we are going to analyze a bone deficiency. When we are looking at defect, we don't need to focus immediately on the bony peak mesial and distal. We have to start from the future final point of the teeth and to decide based on the future position of the tooth which will be the position or the ideal position of the implant. So not immediately look at the bony peaks mesial and distal, because if we are focusing on the future crown position, we can perfectly understand that a part of the defect must be related to a bone augmentation, and the part of the defect is related to a supracrestal compartment, which is not necessarily need to be grafted as a bone deficiency. So the bone defect is to bring the implant on the right distance from the future emergence profile of the crown. And then we have a supracrestal compartment that we may treat as a bone deficiency partially with particularly non-resorbable material, or even better, connective tissue augmentation. So when we are opening a flap, effectively we find two different bony peaks, the interproximal bony peak that allowed us to basically see this defect as a 15 millimeters long defect, or just related to the implant, meaning the buccal bone related to the future implant position, meaning that the defect is 11. And again, we analyze that we have two compartments. One is the bone compartment, where we have to obtain new tissue to place the implants correctly, and one supracrestal compartment that allowed us to have the clinical appearance and nice appearance of our bone augmentation. So obviously, we have a lot of approaches that we can follow to build up the bone, but for sure we have to consider that we have two compartments, and the majority of the case is what we are doing on the soft tissue side that is going to give us the final restoration appearance. So remember regarding the two compartments analysis, because sometimes or many times when we see a patient presenting a clinical deficiency in terms of volume, immediately we are looking and focusing on the bone, and not necessarily the problem is related to the bone, even if we have a deficiency related to the interproximal bony peak. Because if we are thinking about the future tooth position, and then we generate the space to develop the emergence profile of the crown and the seal around that potential future crown position, we realize that the bone for the implant is already there. So the defect is existing clinically, but is referred to the supracrestal compartment area, and we may treat this simply with a connective tissue graft. So to increase the volume and change completely the clinical appearance in this scenario, also from an horizontal point of view, just by thickening the tissue supracrestally, not buccally, supracrestally, and obtaining a nice final restoration and the natural appearance of this restoration. So every time that we are looking at a case, we have to focus and ask ourselves which will be the future crown position, because this apparently seems to be a vertical deficiency, but it's not at all, because just by mirroring the neighboring tooth, we realize that the space between the future crown emergence profile and the bone is already the 3.5 millimeter indicated from the literature to optimize the emergence profile of the crown. And it means that in this case, we don't have to do a bone augmentation procedure, as for example in this case has been done, going over the natural contour of the bone, try to build up something that is absolutely not needed, and realizing this at the time of implant placement, where we are needs then to place the implant 3.5 or 4 millimeters deeper, and was simply needed maybe the implant positioning, and in presence of a connective or a volume deficiency, a connective tissue graft was the simple way to treat this case. About the material, obviously we have a lot of materials. We know that autogenous bone, particularly when we are talking about critical size defect in the vertical direction, is the best material that we can use because it's stimulating and supporting the biological process. And we know that high percentage of autogenous bone are effectively change the biological process, or better, they are effectively supporting the biological process in bone augmentation. Regarding the soft tissue, the supracrestal augmentation connective tissue is the best material that we can select, is the most stable, the most effective, and the most predictable in terms of regeneration. And doesn't matter how much bone was missing at the beginning, the important thing is to recreate the supracrestal volume that is going to give us back the natural appearance of the tooth and the proportion with the neighboring dentition. About the technique, obviously we have a lot of techniques. in the literature, we have a lot of techniques reported also in these 3 days. You're going to see amazing things. Obviously, what is important is the predictability, because this is the key point for the patient. It's not necessarily the technique itself, but what is important is what we are doing is going to be predictable, to be effective, and to remain there for long time. And in this case, for example, horizontal bone augmentation, following the Curis protocol, the shell technique with the horizontal bone augmentation in the premolar and molar area. And you see here the initial situation, the post-treatment, the 12 years clinical appearance, the 12 years stability, because we follow the genetic envelope, which is a crucial part of the treatment and of the strategy. So following the architecture of this maxilla, and the situation after 15 years and 18 years, again, of stability after the bone augmentation, with a very nice soft tissue and hard tissue relationship. And again, you can appreciate that from the first bone to bone contact to the implant to the emergence profile of the crown, we have this 3.6, 3.5 millimeters. So the graft position is crucial, particularly if we are working with autogenous bone, because autogenous bone is not able to work outside the anatomical contour. The physiologic turnover of the bone will bring the bone back. So when we have to graft, we have to consider the genetic envelope, and we have to work inside the genetic envelope. Why? Because the muscle activity that we have in the mouth everywhere, particularly in the upper jaw, with the upper lip, tension is going to generate a resorption of the bone outside the anatomical contour, maintaining just what is inside the genetic envelope. Regarding the techniques, as I mentioned, we have a lot of options, and the literature till now is still failing long-term to tell us which technique is better. So we have both options. We have GBR, we have blocks. If done in the right way, they are going to be predictable and stable during the years. Also, because we have the same biological background. We have to think that every time we are building up the bone, if we have the bone at the end of the procedure or at the end of the healing period, the biologic performance of the biologic sequence of the event is an intramembranous ossification, because one biological process allowed our body to obtain bone in that area. So what about the digital impact, the modern approach regarding, for example, collecting autogenous bone? Nowadays, we have strategies regarding digital approach, meaning that we can use guided bone harvesting, for example. We can allowed us to define before starting the surgery how much bone is needed, how we can collect, and as a three-dimensional ruler is going to allow us to replicate those anatomica or those osteotomy lines to be safe, and at the same time to collect the right amount of bone volume needed to treat the deficiency, because the starting point every time is the bone missing in the area to define the dimension of the block that is going to be harvested. And this we know that is going to be safe, that is going to change the quantity of bone available for the bone augmentation, and obviously is going to reduce the skill needed to perform the procedure. In terms of precision, we know that the clinical mistakes is less than 1 millimeter in performing these osteotomies, so we are very safe from a strategical point of view. And what we can do nowadays is also to work fully guided, meaning from harvesting, from management, and from guided fixation of the lamina, meaning that we can decide everything in advance, and we can then follow all the procedure just by a digital guide, by references that allowed us to prepare everything outside the mouth and place everything in the right position. And obviously the healing is going to be biological as usual, meaning bone in 4 months. So obviously this means control, and when we have a control of the procedure, we are going to have also predictability. But going back on the aesthetic area, how we can manage this type of situation, not starting the surgery and thinking, okay, now I will start and then we are going to see how I'm coming out. We need a strategy, we need a planning every time, starting from the final position of the teeth, understand how much bone is needed to be built up, which will be the distance at the end from the implant, shoulder to the emergence profile of the crown. This is crucial. So guided bone harvesting in the posterior, but not just this, we can pre-visualize everything on the bone augmentation, dividing the block guided, so that we are going to approach the case with the full guidance of what we are going to do. Rebuilding vertically the buccal and lingual lamina using autogenous bone in the vertical area, pure, then mixed with some bovine bone in the area where we have an horizontal deficiency present. But this is how it's going to change the aspect of this maxilla. From a deficiency area 4 months later, now we have a very nice shape of this maxilla following the genetic envelope, and this is the bone. 4 months later, we can place our implants. If we want, we can protect this with some bovine bone or not. It depends on the genetic envelope and the dimension of the anatomical basis. But now we change completely the distance between the digital mock-up at the beginning and the bone healed, with the implant healed, before the soft tissue management, which is crucial because it's going to determine the last step for the natural appearance of these teeth. And obviously, we have also to move back the mucogingival line. And every time we have a patient that has a lot of connective tissue available, we can build up the soft tissue, particularly on the crestal area, meaning we have to look on the supracrestal compartment to allow us to compensate vertical, the supracrestal area, where the teeth are going to shape then the tissue and give the emergence profile and interproximal space well shaped and in harmony with the natural dentition that is still present, for example, in these patients. So the initial situation, the final situation with the temporary bridges placed, the distance clinically on the mock-up, and the final situation of the tissue with a very nice volume that is again based on a vertical bone augmentation and on a soft tissue vertical augmentation, because it's the verticality that we have to build it up back to reshape then the tissue with the prosthetic. The previous smile line of the patient, the smile line now with a gingival appearance, with the teeth that are coming from 21 millimeters at the beginning to a normal dimension at the end of the treatment. This is again clinical view, the X-ray after the treatment, and again you see how the bone needs to bring the implant shoulder at the right position, at the right distance to the emergence profile of the crown, and then the interproximal, the supracrestal area is developed by the soft tissue augmentation. This is after 5 years clinical appearance. This is after 7 years from a bone perspective with a very nice stability after the physiologic turnover of the bone. And the STL file after 7 years matched with the initial situation, just to understand how much has been developed, the bone and the soft tissue on the original shape of the crest. Now, what about the flap? Because it's a key factor. Every time we have to think about having a right soft tissue manipulation, how many times we saw these pictures related to the concept of flap passivation, but we have to remember that the passivation is something that we cannot measure in length. We have to measure in Newton because it's a force. And this is justifying how many times we are looking these numbers and we are surprised about the complication related to vertical bone augmentation, just because sometimes we are mismatching the analysis of the passivation, because the passivation is strongly related to the force that is used to the suture to obtain the wound stability, and minimal amount of force is going to determine a high risk of complication. So we have to have a strategy again from soft tissue management, thinking about the flap design that in the upper jaw is very peculiar, is very different from the lower jaw. Flap elongation that is not flap passivation, but is just to make the flap longer, and the wound closure strategy. So what is the main problem on the soft tissue or the flap management in the upper jaw? Is that the palatal flap will be too short, because we cannot elongate the palatal flap. If we are starting in a condition like this, it's very difficult to have the wound closure at the top of the crest with an horizontal mattress suture interaction between the inner face of one flap and the inner face of the other flap. So we have to think differently. We have to anticipate the length of the palatal flap by changing the position of the incision. And we know the information regarding this shifting because we know the dimension of the deficiency. And by adding the dimension of the vertical deficiency plus 4 millimeters, we are going to obtain a long palatal flap that allowed us to seal the wound perfectly on top of the future crest. So the incision sounds quite strange because it's a buccally shifted incision that allowed us to have a very nice palatal flap that is verticalized, that is reaching the optimal position in terms of wound closure. And then we have to work on the buccal flap to elongate the buccal flap properly, but we are reaching immediately the optimal position on the palatal side. And this is well described in this paper from 2021, and this is the first step. The second one will be how we can elongate the flap, and it's important to work interrupting the periosteum for sure, and then increasing the length of the flap. And in the last years, this is changing and change quite differently compared to the past, because one of the main problems by doing this is that we are moving the muscle towards the coronal part, losing completely the depth of the fornix. So how we can change the strategy, how we can do a bone augmentation vertical without losing the position of the fornix, meaning without destroying the natural appearance of our alveolar crest, by shifting from a typical bone augmentation flap to a more mucogingival design flap. In this way, we can work by advancing coronally the flap, keeping anyway the thickness of the flap, but without losing the vestibulum, without losing the fornix. And this is just after 2 weeks post the vertical bone augmentation, or cases like this, where we have a very poor starting condition, but again, combining a buccal shafted incision plus a platform connective tissue graft as described by Giovanni Zocchelli, we can increase the verticality of the tissue, we can do without losing the position of the fornix, and it means that we don't need at the end to make an apically reposition flap to recreate the space and the fornix depth. What about the sutures? The sutures is a crucial point. We mentioned that we need to have a very low tension condition, and the best way to obtain this and control this is to using breaking force stitches that are not generating ischemia on the flap, reducing the force applied to the horizontal mattress suture, which are the very dangerous point of our wound closure. And we are going to see this last case that is going to summarize the concept that we have seen till now. Very problematic case in the aesthetic area, 2 failing implants that must be extracted. We have an 8 millimeters vertical deficiency. We have a lack of soft tissue. We have a lot of problem related also to the flap management. How we can do this? We can start first of all by shifting the incision, meaning increasing the length of the palatal flap. And since the defect is 8 millimeters, we are going to add the 8 millimeters, the 4 needed to seal the wound. So by performing an incision that is buccally shifted in the area of the vertical deficiency, this is going to allow us to have the maximum verticality of the palatal flap, or better, to have the palatal flap that is already reaching its final position since the beginning of the surgery. Obviously, we are going to work slightly more on the buccal aspect, on the buccal flap, but this is going to change completely the risk of wound dehiscence during the healing phase, because the palatal flap is exactly on top of the future crest. Obviously, we are going to collect the bone, we are going to recreate the verticality following the genetic envelope, so no over contouring, no rounded shape of the crest, is a straight connection from the mesial and distal bony peak, also in the horizontal plane. And look again how the incision is shifted, but where the wound is closed. That is exactly on top of the future crest, exactly on the optimal place where the buccal flap and the vestibular flap can be coupled together with the inner face. We wait for months. This is the quality of the bone. Now we can round at the crest, but now we can start, since we didn't move the muscle attachment to the coronal area, to increase the verticality of the tissue, meaning working with connective tissue as a non-lay on top of the regenerated area. Why we are doing this? Because we want to arrive to the mucogingival surgery with a very nice volume of tissue over the implant, because this will help the prosthodontist to develop the emergence profile of the future crown. So we have every time a lot of tissue. Obviously, we have to correct the mucogingival line position, but you see in this picture that the vestibulum is still in position. So what we're going to do is a very superficial, very superficial repositioning of the mucogingival line, and we have the chance to increase again the verticality, so that we are moving from this to this condition, and from this point to this situation and relationship, so that the prosthodontist then can finalize the case in an optimal situation, integrating the new implants in the natural appearance of the rest of the dentition. So it's very important every time we are approaching a vertical bone augmentation, or in general a bone augmentation, to do the right diagnosis, to select the material where the autogenous bone is for sure one of the most important aspects, select the technique, and we have a lot of the techniques that can work, and an accurate flap management, because what we have to do is to reduce the invasiveness of this treatment, is to increase the predictability, meaning reducing the needs of retreatment. Thank you very much for your attention.
Thank you so much. Thank you very much, Luca. This was very impressive, and I have to say, very surgical. Both presentations, so beautiful surgeries, amazing, huge flaps, a lot of bone, a lot of soft tissues. I feel the pain of these patients also a little bit. So we have to really discuss this later on. When should we really do all this approach and all these surgical efforts? And when can we have nicer, maybe easier prosthetic solutions for these patients, or for some patients at least? Well, the prosthetic aspect is of course important. Pink ceramics, pink materials is of course important, and the development of beautiful aesthetics in these multiple missing anterior segments is definitely in the end a prosthetic challenge. And we've invited an expert in prosthodontics to talk to you about this. It's Carlo Monaco, and I would like to invite you to the stage, please. He is a specialist. He has studied in Bologna. He is a master in, and also a PhD in material sciences, so he has a huge knowledge that he's teaching to students at the University of Modena, and at the same time not only working at academia, in academia, but also in a private practice together with Giovanni Zucchelli. And I would like to invite you to come to the stage and to show us your concept of how in your practice you deal with multiple missing teeth in the aesthetic area. How do you control the pink and the white aesthetics, and how much do you augment and how much do you replace with prosthetic materials? Thank you for having accepted.
Thank you, Irena. Thank you so much, and I would like to thank the organization for my kind invitation. And my lecture, please, could you transfer my presentation? Okay, and first of all, I would like to thank Massimo, Irena, and I would like to thank my teams. Okay, can you switch the... Okay. Thank you. Okay, and I see on the screen, but my lecture, okay, and this is our team, because it's very important to work in a very big team, not only with the surgeon, but with the dental laboratory and new technologies. It's very important to finalize the clinical case in very excellent way. And Prosto is involved in a lot of points when we do a restoration on implant. Anna, before me, talked about the planning, and Luca talked about the surgery, but a lot of points needed to the Prosto treatment. And We talked before about the possibility to have an excellent result, to have an excellent dimension of the papilla, and Tarno described on the natural teeth that the distance between the contact point and the bone is it's crucial point to understand which is the best situation to recreate the papilla. And when we have only one implant near the tooth, it's the same situation, and it's more easier. It's easier for me to recreate the papilla in this case. But when we have more implant, as discussed before, we need a lot of things to do, because we need to choose an excellent shape or hybrid design of the implant. We need to choose an excellent diameter of the abutment. It's very important. It's a very crucial situation. It's very crucial. And this is the reason why with the surgery and before the surgery, the prosthet need to recreate all details related to the workup or digital workup, and explain which is the best type of implant, the best type of abutment that needed in some case. Because in some, or it's not easy for me when I need to recreate an excellent mucosa tunnel with no excellent choice or choose of the implant. And the other very big difference between the single implant and the multiple implant is related to the time. Because when we put an implant in anterior area and as a single tooth, we spend less time, at least in 6 months, we can finalize the case, we can arrive to the excellent final result. And the other question is, which is the best shape of the provisional restoration in this situation? The shape of the provisional restoration is very similar to the final restoration, because during the healing process, the soft tissue can grow near the perfect shape, and we can work on the shape, and we spend very few time on the shape until arrive to the final restoration. Of course, we need to take a digital impression, and we talked before about this topic. But when we are in anterior area with a multiple situation, with a multiple loss of teeth, we need a different type of choose a different type of time. Because first of all, in some case, we have some periodontal problem, some problem related to the infection, and we need to wait more time, and we need to spend a lot of time, 4 to 6 months, to understand which is the best situation for the bone augmentation or soft tissue augmentation, or both bone and soft tissue augmentation. This is the reason why we use a lot of Maryland bridge in metal, because we in some cases we cannot touch the adjacent teeth, and we need to bond with the resin cement the Maryland bridge. And then after 10 months, 8 months, we can decide to put an implant, and the treatment or the conditioning of soft tissue is a little bit difficult than in a single area. Because we need to create the mucosa tunnel completely. And we have more treat time than the single implant. And first of all, I would like to discuss with you about the change of the mucogingival junction and the relationship then I need to create with the mucogingival junction, and which is the best type of conditioning of with prosthetic, with provisional restoration. In this case, as you can see, we don't have the papilla, we don't have buccal volume, and we need to increase the volume. But which is the best situation, bone or soft tissue augmentation? From the prosthetic point of view, I prefer have a more soft tissue, because it's easier for me to press the soft tissue, to condition the soft tissue, and to create the ideal shape for the final restoration. The approach is the same the provisional restoration, as marginal restoration, and Giovanni do the surgery, increasing the soft tissue. And as you can see, it's very important to increase the soft tissue near the papilla, because I have to recreate the natural papilla in that area. It's not so easy to do that. And then, in some case, related to the design of the flap, related to the movement of the flap, we have a different line for the mucogingival position of the line. And this is the reason why I have to spend more and more time to press the mucogingival junction more apical without touch the papilla. And it's not so easy to do. And in some cases, when we put the implant in waiting after the first surgery, we can increase the amount of soft tissue during at the same stage during the implant position. And it's very important. And now I have to wait 4 months at least. I have to reduce the provisional restoration, and then after 4 months we can uncovering the implants. We can use a vertical in some cases, not in all of the cases, but in some cases we have to use a vertical narrow abutment to avoid the pressure on the mesial and distal papilla. And as you can see, I have to check the ischemia of the papilla, and if I check the white color of the papilla, I need to remove resin on provisional restoration, and I press the mucogingival line more apical, and then I wait 1 or 2 weeks. But it's very important to avoid the pressure of the papilla. Which is the best design for the provisional restoration? The best design of a provisional restoration is a provisional restoration concave, like this situation, and I can modify the provisional restoration during the next time. The digital solution is excellent for me because we can combine and print digital model with soft tissue, combine all information, and dental technician can have a lot of information to create the perfect design of the abutment restoration. This is second provisional restoration, and it's important when I use the second provisional restoration, avoid to press the mucogingival line or to press the papilla. And now I'm creating the mucosa tunnel in the deeper area of the implant, and then I can check the provisional restoration, and I can design with the diamond burrs the more coronal part of the tunnel of the mucosa tunnel. It is very important. Avoid to press. It's more important to recreate the situation of healing and to restart the new healing near the provisional restoration. And then I can modify the provisional restoration with a flowable composite, resin composite, in a few space in the mesial distal part, or I can press on the emergence profile, the buccal emergence profile. In this way, I have to, after 2 or 3 months, or in 2 or 3 times, I press the mucogingival line and I modify the shape of the mucosa tunnel. It's very important to create and to give to the dental laboratory a lot of information starting from the CBCT. In this way, the dental laboratory can create a perfect design on the final abutment. And when I write the final restoration, I work on the emergence line, on emergence profile, and I work on the design of the contact point. It's very important to reduce, or in some cases increase, but I prefer to reduce the zirconia restoration in that area. It's very, very important to obtain an excellent result. As you can see, the previous situation, the final situation, and the buccal situation, and the final situation after 4 years. as you can see, excellent the stabilization of soft tissue and excellent position of the papilla, and excellent situation of the bone of the X-ray image. After 5 years, we have the same thing, the same result, and the excellent maintenance of the buccal soft tissue. It's very important to introduce a digital workflow in our clinical practice, because the digital workflow can do to the dental laboratory a lot of information. As you can see, this is the same approach in this clinical case. I removed the old restoration. Giovanni starting with the soft tissue augmentation on right side, on the left side, and then I have to wait 3 or 4 months, reducing the provisional restoration to leave at least 1 and 1/2 millimeter to protect the soft tissue and to promote the growth of the soft tissue. And then only after this treatment we can planning the position of the implant, and we can open and uncovering the implant and starting with the provisional conditioning of the soft tissue. For the pontic element, we avoid to use a very strong pontic element. I prefer to reduce in that area with diamond bursts, and as I told before, it's very important. Many years ago, I published 2 papers for the transfer a lot of information to the dental laboratory related on the design of the mucosa tunnel and on the design of the provisional restoration. And at the same time, the dental technician will receive a lot of information. When the dental technician starting with the final restoration, in the anterior area, when we have more than 2 or 3 or 4 implants, we use the prototype concept, and it's very important for us to avoid, when you use a prototype concept, to press the soft tissue. The prototype concept, the prototype restoration is made only to check the quality of the digital impression and check the quality of the aesthetic smile. And it's not important at this stage to press the soft tissue, conditioning the soft tissue, and understand which is the best situation. Because there is a big difference between PMMA and zirconia material. Zirconia material has a more biocompatibility than PMMA, and the soft tissue can grow better than the provisional restoration. The prototype concept is important only to check the quality of the position of the analog inside of the model, to fix in a final way the restoration. And as you can see, I spent a lot of time to understand which is the best smile for the patient, change the dimension, and change the line. This is the reason why, for me, it's very easier to work with soft tissue. And if I have more than 4 millimeters of soft tissue, during the final restoration, I can press the soft tissue and change the smile of the patient. Other question is very important in combination with the dental laboratory, because as you can see, this similar clinical case after the motorbike crash, and the patient have a lot of problem, and we check, first of all, with X-ray, the level of the peak of bone, and we decide if it's better in this case to do bone graft or soft tissue graft. And in this case, we use, as I told before, only soft tissue graft, same protocol, provisional restoration, and Giovanni do the increasing of the soft tissue. In one stage, we wait 3-4 months before to take the CBCT and to put in the implant. But as you can see, we need to grow the soft tissue in the buccal area. And for this reason, we have to wait. And then, if we have some lack of soft tissue, in the second stage, we can increase in the buccal or in the occlusal area the soft tissue to increase the aesthetic final result. The reduction is the same, 1.5 millimeter in two or three times, and then we can plan the final position of the implant. And in a lot of cases, we find a lot of bone or a sufficient bone to put implant, avoiding the bone regeneration. As Luca told in his presentation. As you can see, the worst situation, but in the worst situation, we have a lot of space and we can decide to use a narrow implant in that case. And then, in the second, during the implant position, Giovanni can increase the soft tissue. This is the reason why I can put immediately the provisional restoration. I have to avoid the conditioning in that area, at that stage, and I have to wait. We can only put the healing abutment, and then we can open the healing abutment and starting with the new conditioning situation, new conditioning phases. The scan body is very important, and digital impression is very important to transfer information. The abrasion with the diamond burst for the pontic element without to press more, because if you press, you can change the position of the papilla. And it's very important from prosthetic and laboratory point of view, decide with dental laboratory which is the best dimension of the abutment, because the soft tissue needs space and we have to live to space in different way. And if it's not possible to use a commercial abutment, we create a customized abutment for the patient, but with same concept to little space for the connective soft tissue. And if I have a pressure, I remove the provisional restoration, remove a lot of amount of PMMA in that area, and then I can reinsert the provisional restoration. It's very important to avoid pressure in the area of papilla. It's very, very important. And then, with the provisional restoration, we can conditioning the papilla, we can conditioning the emergence line, the gingival buccal emergence line in 2 or 3 months, and then we can transfer and direct transfer or start with the final zirconia restoration. In the past, we spent a lot of time with the provisional restoration, but now, after 2 or 3 months, I immediately go directly and use a zirconia restoration as a second provisional restoration, because the answer for the healing of the soft tissue is better than with the provisional resin. And then, this is the final case. In this situation, I can decide with the patient to opening the space between the papilla, between the tooth, and decide the length, the correct length of the natural, of the restoration. Yeah. And at the end of my presentation, I would like to talk about some not complication, like small complication, not failure, because when we have a failure with bone graft augmentation, it's more difficult to recreate the new excellent situation. But if we have a failure or a complication with a soft tissue augmentation, it's easier to treat. And I would like to show the last 2 cases with 2 different situations. As you can see, in multiple missing teeth. In some cases, we can have an exposure of a connective soft tissue near the papilla. And in the past, we wait or change the provisional restoration or change the shape. Now, I finalize the case. I immediately use a zirconia restoration and wait, and that's it. And I wait 3 months, 6 months, it's not important. And then we can, with a small abrasion, we can modify or we can optimize the shape of the papilla. In some case, the last case I would like to present you is very worst situation for the patient, and it's very best, the dramatic situation for the canine. I have to remove the old, the provisional restoration, recreate the new abutment, and Giovanni increased a lot of amount of soft tissue. But during the phase of the provisional, during the uncovering of the implants, we found a very bad situation, and I work with provisional restoration, but it's not important for me to spend more time with the provisional restoration. I directly start with the final restoration. Zirconia restoration is the best material for the soft tissue, and this is the reason why in a situation like this, we have to condition 1 month, no more, 2 months, no more, with provisional restoration, and then start with the zirconia restoration and wait. In this way, the papilla can grow directly. At the end of my, this is the final case, and the final result after the surgery and after prosto treatment. In conclusion, first of all, we need to plan with the three digital design, because we can know exactly which is the best situation of the implant. It's mandatory to have a lot of soft tissue for the prosto, because it's better to pressure or modify the shape. And then we have to press only in the buccal area and not in the area of papilla. It's very important. And when we treat the papilla in the multiple missing teeth, we condition slowly the papilla, because in one time is not so excellent. We have to spend 2 or 3 times for the conditioning of the soft tissue in the papilla area, and then we have to use the digital impression to transfer a lot of information directly to the dental laboratory from the provisional restoration to the final restoration. And last 10 or 4 years, I immediately use zirconia restoration as a second provisional restoration, because only in this way I can wait the final growth of the papilla, final growth of the emergence profile, and if I have some problem, I can reduce the zirconia, or I can send directly to the dental laboratory for small change of the restoration. Thanks a lot. Thank you very much for your kind attention. And we can start with the discussion.
Thank you, Carlo, for the wonderful presentation. Looks like you have a good surgeon you work with.
Yeah, it's a good surgeon.
And so please.
Thank you.
We are ready for the discussion. No, this is much.
Last one.
Okay.
So, dear colleagues, if ever, please stay, because we have really an exciting topic to discuss here with really controversial, I would say, thoughts that is worth listening to.
So we have a first question to the three of you. Is a question that arrived from the audience, but that we wanted to do in advance already. So, and you have shown that in case of missing the 4 incisors, so 4 teeth in anesthetic areas, you have different options. One is to place 1 implant by teeth, so
yes.
4 implants. The
Yes.
other one is to place 2 implants at the level of the lateral incisors. The third one is to place 2 implants at the level of the centrals, and
Yes.
then there is another one
Yes.
yes and
one
one
central
no.
and one lateral. Yes.
So I would like to ask to the
Dear
panel.
colleagues, could you please stay, or if you go out, please do it silently so that we can move on with the discussion. Thank you.
What is your preference, and what could be the advantages or disadvantages of the different solutions?
Yeah, it's from prosto point of view, it's better to have in the multiple missing teeth no
Together.
no together. Yeah, because it's it's more difficult to create the papilla.
Yeah, it's easier to maintain a large space.
This is the reason why we can put one implant, Pontic, and one implant. If it's possible. If we cannot do that, we can choose very, very narrow implant. We have to choose very narrow abutment to recreate the space between the soft for the
So you prefer to place only 2 implants at the level of the laterals and have the central incisor as a
not necessarily at the level of lateral, but we put 2 implants in choosing the best position related to the bone. If we have the bone in the central incisor or in lateral, we can put the implant in the best amount of bone, natural bone of the patient. Not prosthetic situation on lateral or in central. It's related to the clinical case.
And what
I
is
would
your...
say that I cannot speak the same now than I was speaking a couple of years ago because of 2 things. First of all, we are using always now the digital technology, so we know exactly where our implants are going to be placed. And then because of the peri-implantitis, we have to never forget that if you have 2 implants for 4 teeth and one gets a peri-implantitis, what do? So now I am more going for a little more implants, maybe not 1 implant per tooth, but I must say that when I have the space and the bone, for 4 implants, I could go for 4 implants per tooth if I have the bone and the space. If not, I would go for 2 or 3 because I have been confronted to old cases and to treat the peri-implantitis was a very big, because patients are coming with a fixed bridge and suddenly you tell them that you are going to remove the fixed bridge because there is a peri-implantitis on 1 implant, so 1 support, and so no more bridge, and they would never go back to anything else. So because of all of this, today I would place maybe more implant. If I have the bone, of course, every case is different.
But maybe Anne, because the questions came up, how do you manage the soft tissues then inter-implant to create the prosthetic appearance of a papilla? That's the most difficult, and that's exactly what Carlo just pointed out.
I manage it much better when I have implants 1 per tooth, because I have the bony peak, and even if I know that it's not always the condition, I always augment the soft tissue and the bone. And if I have 1 implant near another implant and I have the bone peak, I'm done for the next 10 years. I'm fine.
Yeah, but usually the most difficult thing is to have the bone peak in between 2 implants. That's why we have to respect the rule of 4 millimeters. So the more implants you put, the more difficult it is. So that's kind of a strange thing. Usually when you use the 2 pontics at the level of the central incisors, the interdental papilla is much easier to be obtained because you create a lot of, you build up the soft tissues, and with the pressure of the 2 pontics on soft tissue, on the bone, it's very easy to create an interdental papilla. If you have 2 implants together...
Yes, it's not a big interdental papilla. You have to have a small papilla. So it never looks as nice as if you have 2 implants placed perfectly, and then you have a real papilla. And it's true that for the first years, yes, we have an interdental papilla, yes, if we make it, like you say, with 2 pontics, but in the time it shrinks. And because you don't have these peaks between the 2 pontics. And so in the time it shrinks, and in the time the patients are starting to brush between the 2, and then you have the black triangle. And then what do? Remove the bridge, do soft tissue again.
So you think that the underlying bone is very important to maintain the interdental papilla?
Yes, definitely.
Luca?
I'm placing less implants. I'm more aligned with Carlo. I mean, if I reduce the number of the implants and I graft eventually supracrestally, I mean, what is important that I think was a little bit, at least I'm talking for my experience, that years ago we were more grafting baccally, and now we are grafting over the crest to recreate the tissue for the prosthodontist. Because to develop the architecture of the future teeth, in many cases, is subtractive. So the prosthodontist is taking out the volume that has been grafted, keeping the interproximal volume. And in this way is managing the development of the papilla. So, and I think it's not every time needed to have exactly a bony peak under a papilla. I mean, it depends on the volume that you have recreated on top.
So do you think, like Anne, that it's very important to have enough bone underneath the soft tissue to have a nice papilla, or you can compensate with soft tissues only?
So I mean, if I can place the implant on the right distance to the future emergence profile, then the interproximal volume can compensate it just by connective tissue.
Even though you don't have the infrabony peak?
Even if I don't have infrabony peak.
Maybe a question that arose also from our audience here, but we also had in mind, how do you, the flap design that you're doing is a little bit special. How do you take care of the aesthetics of the mucogingival part after the healing, because you have moved all the buccal part mostly to the crest?
Yeah. We move, one important point, we are not moving the muscle component of the buccal part. Otherwise, it's very difficult to recreate the natural appearance of the arch. So the important point is that we can advance buccally the flap, or better, coronally the buccal flap, but it's just a superficial component of that flap, not the submucosa and not the muscle. In this way, the vestibulum is not changing the depth, it's changing the mucogingival line, obviously, but then is much easier to replace the position of the mucogingival line because we need just to work on the surface of the recreated crest.
Is that a risk of thinning too much the flap and compromising
and
the
compromise the bone augmentation? This is a point, and it depends on the level where we are starting to split the flap. It's obvious that if we are focusing or we are replicating the mucogingival flap, meaning that we are starting at the mucogingival line to split the flap, then is a risk of fenestration for sure, because you are thinning the flap too early.
Yeah.
But when we are starting where the muscle, the vestibulum is present, so we are keeping the entire thickness of the flap till the vestibulum, and at the vestibulum level we are splitting, being very superficial, then there is no risk of fenestration, because that part of thin flap is never on the risky coronal part of the bone augmentation.
And do you prefer to do that in the first stage surgery when you do the bone augmentation, or at the second stage surgery when you place implants and maybe the connective tissue on top?
If I can try, I do immediately at the bone augmentation stage, because in this way I can add the connective tissue and correct eventually the mucogingival line at the implant placement, and having no second stage implant surgery with the flap, because I need just to make a hole on the flap.
Okay.
So for the patient is potentially one surgery less.
But then again, another question that came up to you specifically, Carlo, is what is your experience for the long-term stability of these huge connective tissue grafts? And a question to all of you also is, do we really always need to do all these huge grafting procedures? They're so painful and take a lot of time. Can we not just solve it with pink ceramic?
Yeah. I told before.
I know that
Luca,
Giovanni loves
related this a question, and in our experience, more than 20 years, the big amount augmentation of soft tissue create more stable situation for the implant. And before I talked with Luca related to which is the best space for the mucosa tunnel, and often it's only my opinion, of course, often I find an excellent situation when I have more mucosa tunnel than very 2 or 3 millimeter, because in the deeper area of the mucosa tunnel, often when I remove the restoration, I can find inflammation. I find inflammation near the coronal area. This is the reason why the soft tissue are very, very stable and are very stable near the implants. And the other question is related to the papilla. The papilla is stable at the same time. In some cases, Giovanni, not in multiple missing teeth, but in some cases, Giovanni changed a little bit the technique, the surgical technique, because the soft tissue can increase the volume after the time and not decrease. This is the reason why it's easy for me to, in the future of the patient, to modify a little bit the final restoration when the final restoration is correct. for me, it's a positive situation and very, very stable soft tissue in the time.
May I make the comment regarding the pain of the patient? I mean, we have a nice study, which is a randomized clinical trial published by University of Zurich, showing that in patient perspective, harvesting autogenous bone or not harvesting autogenous bone in a bone augmentation procedure, if the bone harvesting is done in the retromolar area, the patient experience post-operative is exactly the same. The patient is assuming the same amount of painkillers in no harvesting or harvesting situation. So, and usually, and now I report my experience, the pain can be controlled very well, and the important part is the first 24 hours. That is the crucial moment. And if I have to say, is more obviously the mucogingival part, when we are maybe extensive or having extensive graft, soft tissue graft, that the patient is experiencing more pain during the postoperative phase. But for the bone augmentation, you may have swelling, but usually pain, and I'm sure that Massimo can confirm for GBR. I mean, when you do something on the hard tissue, the pain is relatively limited. You may have a lot of swelling, but not pain. And this must be underlined because obviously we are impressed maybe due to the volume, but at the end, working on one side or two sides for the patient, it doesn't mean that we have the painkiller of the left side and the painkiller of the right side. The pills is the same. And
they suffer much more
for
the collecting of the soft tissue from the palate.
Yeah, eventually, yes.
So if it is thick, yeah. And I have another question to the audience, to the panel, sorry. I've seen in narrow ridges, instead of augmenting the bone, using narrow implants, like 3.3 millimeters implants, also in situation in which you have a kind of a cantilever in a frontal direction. Do you think that could be something from a biomechanical point of view dangerous or risky, or you do that?
Yeah, when we use a very narrow implant, we use a rock-solid system that combines titanium and zirconia. This is the reason why the mechanical properties of the implant is higher than the traditional titanium. This is the first question. The other question, in my opinion, is the length of the neck. When I have a 3.3 diameter, if I have a bone level, the movement of the abutment is more longer than when I use a tissue level. This is the reason why in our choice, or when we choose which is the best situation, Giovanni increased the soft tissue, I increase the length of the neck of the implant, because the fulcrum of the implant is near the neck. If I increase the neck of the implant, I move the critical point more coronal. This is the reason why we use a lot of tissue level implant and very few bone level implant for mechanical point of view. And the other question is related to the one abutment one time. Yeah, one abutment one time is excellent situation to recreate all the biological area near the implant, but probably from the mechanical point of view, we have a two screw. One screw is smaller than the other, and we can have more mechanical problems. The mechanical problems are related to the number of the implant, the position of the implant. This is the reason why we can choose, first of all, the number of the implant, the neck of the implant, and then we can choose if it's better bone level, tissue level, or one abutment one time.
Okay, thank you very much. There is another question in a similar topic. We have seen two teeth on one implant. So one implant, one tooth with the cantilever. And all of you do this, or do you think it's a little bit risky, for example, to have a central incisor with the lateral incisor as a cantilever, or vice versa?
Yeah, I think that
there's the risk of unscrewing or mechanical risk.
No, I think that the main risk is for zirconia restoration, not for the implant, because the zirconia restoration is like more fragile than the zirconia implant. And then for the screw of the restoration, in my opinion, it's not a big problem, because when we have this type of situation, we can use a conical screw, and when we use a conical screw, this screw is very, very difficult to have. But I think that the critical point is the zirconia restoration, not the implant.
Okay.
I agree. I think that there is never a problem with the implant, the one that supports the two restorations.
Yeah.
The problems would come more from the restoration, if it's not perfectly adapted, and in occlusion, of course, and everything, and maybe from the zirconia as well. But the implant, there is no danger for the implant.
Yeah, you can have a fracture of the zirconia because you reduce the zirconia to create a papilla, or you can have some problem related to the not discriminant, but fundamental related to the zirconia material. Yeah.
And the reason to do that is to have a cantilever that is easy to manage from the papilla point of view, from the soft tissue point of view.
Yeah, but
and you don't have the risk of having two implants to close each other.
Yeah, but when we use a cantilever situation, probably we have few space, and this is the reason why the stress is not so high, because the stress is related. Is coronal apical, but the other stress is the stress to palatal to buccal. This is the reason why the first thing that we need to reduce to change the area of the fulcrum. This is very important, because if we use a very deep position of implant and very long zirconia restoration inside, we can have a problem.
Okay.
When we reduce, increase the neck of the implant, reduce the dimension of the prosto, and then reduce the stress on the zirconia restoration.
Massimo, I think we're slowly but surely running over time. Would you allow me one last question, because it was not addressed by either one of you? The influence of the smile line of the patient on your decision making, like the medium to high smile line versus the medium to low smile lines. How does it influence your surgical decision?
Obviously, more is evident, more is the perfect integration is a target. But we have to speak clearly with the patient on the perspective. When we were mentioning pink ceramic or not, it's something that is on the table every time. You make a discussion with the patient, you explain the options, and then sometimes even a low smile line or a patient with a low smile line can surprise you saying, I want to have this target, even if the smile line is not showing the gingiva. But this is it's like a psychological thing. If the patient is very motivated and there are the biological background to do that, the smile line is an indication. Pink ceramic is an option, and it's a talk to the patient to find out his solution or her solution.
Not only a talk, because now with the digital avatars, we can show to the patient almost exactly what he will have after the surgery, so he knows. So it's easier to deal now.
So it's informed consent with the patient of which way to go. Carlo, any other approach in your team?
Yeah, we designed with walks-up and discussed with the patient the position of final restoration, but often it's not so easy to replicate the walks-up situation. This is the reason why, if I have more soft tissue, I can move the teeth more coronal or more apical, and then I can change the shape of the teeth. This is very important for me. We never use the artificial gingival ceramic, because I have Giovanni that is the most of the best surgeon in the world. This is my opinion and the opinion of a lot of people, and this is the reason why I prefer you have more soft tissue, because I can, in the final situation, often when the patient arrives in very bad situation, doesn't understand which will be the position of final teeth. And then you can discuss with the patient, but it's not so easy to define the smile line. The smile line, I can talk with the patient related to smile line with the provisional restoration, and often we change the level, more apical or more coronal. And if I have space to go to apical, I can reduce the oppressed with the provisional restoration. Of if I need to have a line, before the surgery, I talked with Giovanni, and I told Giovanni, this is the incisal line, and you have to create more space because we have to move more coronal the position of the teeth.
Yeah, I think that's a very good last statement for a really exciting and very informative session with 3 wonderful lectures addressing this difficult topic from different perspectives. And I think the discussion showed that we're all on the same page.
So, thank you very much. And
thank you very much.